Good morning and welcome to the Peterson Institute for International Economics. This is the second of a two-part series on the PIIE briefing that we just published, edited by Maurice Obstfeld, Adam Posen, and myself. Our first session was on Tuesday, April 6th, and we have the second session today. And our speakers will talk about various issues pertaining to how economic policy should be handled in an age of chronic pandemics. In the order in which they're going to speak, we will have Martin Chorzempa on lessons from East Asia on taming the pandemic, followed by David Wilcox on why US vaccine rollout would solve challenges of equity and hesitancy. And then Mary Lovely on the role of internet access for a fairer fight against the pandemic. Maurice Obstfeld, my co-editor, will provide some concluding remarks. Let me briefly go through the bios of my distinguished colleagues here with us today. So Martin Chorzempa is senior fellow since 2021, and he joined the Peterson Institute as a research fellow in 2017. He gained expertise in financial innovation while in Germany as a Fulbright scholar and a researcher at the Association of German Banks. He conducted research on financial liberalization in Beijing, first as a Luce Scholar at Peking University's China Center for Economic Research, and then at the China Finance 40 Forum, China's leading independent think tank. Martin is working on a forthcoming book on fintech in China, and he has been quoted in the Wall Street Journal, the New York Times, the Washington Post, the Financial Times, MIT Technology Review, and Foreign Affairs, among others. David Wilcox is senior fellow since January 2021. Although he joined the Peterson Institute for International Economics as a non-resident senior fellow in August of 2019. His current research focuses on the US macroeconomy, monetary policy, and diversity and inclusion, especially in the economics profession. Prior to joining the Institute, he served for many years on the staff of the Federal Reserve Board, including as Deputy Director and Director of the Division of Research and Statistics. And in the latter role, he functioned as the chief economist of the division, senior advisor to 3 successive chairs of the Federal Reserve Board. He also served as assistant secretary for economic policy at the US Treasury Department from 1997 to 2001. Mary Lovely is senior fellow at the Institute and also a professor of economics and Melvin A. Eggers Faculty Scholar at Syracuse University's Maxwell School of Citizenship and Public Affairs, where she combines interest in international economics and China's development. During 2011 to 2015, she served as co-editor of the China Economic Review. Her current research projects investigate the effect of China's foreign direct investment policies on trade flows and entry mode, and the relationship between proximity to export markets and cross-city wage variation, and the influence of Chinese tariff reductions on labor shares of value in its manufacturing firms. Finally, Maurice Obstfeld has now been non-resident senior fellow at the Peterson Institute for International Economics since February 2019. He is the class of 1958 professor of economics and former chair of the Department of Economics at the University of California, Berkeley, where he has taught since 1991. He previously taught at Harvard University, the University of Pennsylvania, and Columbia University. In addition to his academic positions, Maurice served as the International Monetary Fund as economic counselor of the IMF and director of the research department, and as member of the US President's Council of Economic Advisors from 2014 to 2015. Mori was an honorary advisor to the Bank of Japan's Institute of Monetary and Economic Studies and has consulted and taught at the IMF, the World Bank, and numerous central banks around the world. So with that, let me pass on the word to Martin, who will start us off with lessons from East Asia. Martin, the floor is yours.
Thank you, Monica, and thank you for the kind introduction. I'm going to talk about lessons from East Asia and the Pacific on taming the pandemic. This is joint work between myself and my wonderful colleague, Tianlei Huang. And this little QR code here will not enroll you in any Chinese contact tracing. It will just bring you to the link to our briefing. So one might be asking, why should we learn from East Asia? And I think the most important reason is that it really shows, the experience of this region shows that public health and economic success are not mutually exclusive in the pandemic. Many countries in East Asia have had some of the lowest death rates of any country in the pandemic, and in addition have managed to keep their economies open for much of this period of time, limiting recourse to devastating lockdowns. We should all try to figure out, I mean, it's not exactly clear, we still a lot we don't know about the pandemic, but there's much we can learn from how East Asia managed to contain it. And one reason that the experience from East Asia and the Pacific is so applicable is that this is not just about one specific type of geography, culture, income level, or political system. We have small developed island democracies like Taiwan and New Zealand handling this extremely well, as well as large middle income countries with authoritarian political systems like China and Vietnam. So it's not just about these factors. A second is that their recent experience, many of these countries with SARS and MERS, some of which were viewed domestically as quite disastrous, including Korea's response to MERS, which led to serious political fallout for its leadership at the time, led these countries to take tough lessons that really helped them be prepared for facing this latest pandemic. So we should learn from their process of learning and preparedness and adaptation that has made them successful. And the third is that the experience cannot be just dismissed as, some people have done about this is compliance or other stereotypes about these populations. One example is Korea is near the bottom of international rankings of trust in government. These are not people who just follow whatever the government tells them to do. Trust in government plunged in China after there was an initial cover-up. And many of these countries are democracies with strong civil liberty protections that could not resort to the kind of coercion that was involved in some of China's responses. And one important example from Korea is that the initial outbreak was among a group, a secretive cult that did not want to comply with anything that contact tracers were trying to do. So yet they still managed to get a handle on it. Policy response that we should study. There is quite a bit of heterogeneity in the way that these countries have responded to the pandemic. For example, how many have resorted to lockdowns or not. Some of this is dependent on the initial severity of the outbreak of the pandemic. In China, it was so widely spread that they had to do a lockdown. But what's important is that from then on, many of them, especially China, were able to use preventative measures and not resort to a repeated lockdown like is, for example, happening in Europe today. Whereas countries like Korea and Taiwan never had to implement lockdowns because they managed to get a handle on the pandemic so well. Yet there are many commonalities in their responses to the pandemic. One is masks. Now the US is talking lots and lots about masks, but in Asia, it's long been a social norm that if you're sick, especially if you're going to go to a crowded space like on a metro, say you have a cold, you should wear a mask so you don't end up infecting other people. This was maybe more acceptable than in some other countries, and hopefully would be more acceptable around the world going forward. Then when the pandemic hit, there were early mask mandates, and in countries like Taiwan, you had provision of masks to the population, unlike in the United States where it was impossible to get masks and US officials actively discouraged people from finding ways to wear them at the beginning. This certainly was a disastrous policy. A second is really focusing on the science and what was different about this pandemic than others. Whereas in Asia, especially places like Japan and Hong Kong, looked at studies and figured out quickly that ventilation was going to be a serious issue, that if this was not just about these droplets that drop after 6 feet, but instead could accumulate in an enclosed space, that was something they figured out early, but the United States is still trying to take this into account. It's kind of stuck in past pandemics and hasn't been as good at focusing on ventilation. The third is widespread testing. If you compare Korea to the United States, for example, by March 2020, Korea had tested 31 times more people per capita than the United States. which is probably one reason that they were able to contain the initial clusters and stop them, and then have very low deaths compared to the United States, where we weren't able to get under control. And one reason is that after MERS, Korea realized that they needed rapid testing extremely quickly and encouraged multiple providers to develop tests, whereas the United States was spending weeks and weeks telling every external provider other than the CDC that they couldn't actually employ any testing, which made us blind in the early time of the pandemic. Another is digital contact tracing, something that's been done a lot in Asia, very little in the West. This is not just about apps, but slow, incomplete manual contact tracing, calling people and asking where they were is just not going to cut it with a fast pandemic. And Korea used this to great effect, and China was able to use its health codes to only force quarantines on people who had been to a high-risk area or had been around someone who was infected, allowing it to reopen the economy relatively quickly after their lockdown. Then another is enforced quarantines for travelers, something, again, the United States has not done at all, and also quarantining known exposures. That helps avoid reinfections from abroad or having infectious people going out and seeding further outbreaks. Finally, clear communication and building trust compared to, in some countries like the United States, top officials spreading misinformation about the pandemic. Now, one common objection to some of these policies is the idea that this is giving up civil liberties for public health. Even if there isn't an economic trade-off, there might be a civil liberties one. And it is true that some of these responses gave up too much liberty. One example is in China, authorities, not all, but some, welded doors shut of people who had been to infected areas. That's obviously excessive. Others, sometimes the contact tracing provided publicly information about individuals who had been infected, which exposed them to harassment and doxing. And in some cases, the data that was collected was leaked because of poor cybersecurity. All of this is a serious problem, should not be replicated elsewhere. But there are ways to maximize the health benefit while minimizing intrusion on liberties. One example is that voluntary quarantine facilities, maybe not forced quarantine facilities, can help infected and exposed individuals not infect their households. One of the most disastrous effects of this in the United States has been that rich people are able, with extra space in their homes, can easily kind of quarantine at home and not infect anybody else. Whereas the poor who live in maybe multi-generational small households watch one infected individual spread it to the rest of the household, which has been terrible for inequality. A voluntary quarantine facility might help that. Another is that we could have limited pandemic exemptions to privacy laws to allow digital contact tracing, like in China. You see this study here on the right, which was one of the most important early signs that the virus was airborne. It contributed immensely to not only the control of the pandemic in China and in Korea, but also to understanding how this pandemic spread. Nothing like this has come out of the US. You just can't do it with these kind of manual contact tracings. However, each country has to make its own trade-off. In conclusion, I would say that the temporary targeted restrictions and monitoring that many countries in Asia did are far better for civil liberty than locking down populations of millions of people, in some cases multiple times, and then the deaths of hundreds of thousands that have resulted outside of East Asia. This cannot be just dismissed as different cultures or obedient populations. This is about good, strong, sustained government policies that learn from the past and earn the buy-in of society through positive results, and should be emulated as much as possible. Thank you. You're muted, Mike.
Yes, the usual on Zoom. So two key messages, I think, from your presentation. The first, which you started off with, the fact that you cannot separate public health from economics. They're not mutually exclusive. And the experiences of Asian countries show that very clearly. And number two, if you act early and you have the trust of the population in general, there's a lot that you can achieve in terms of controlling the epidemic without having to go all out and do several intermittent lockdowns, which may actually have terrible effects for the economy at the end of the day and not do much in terms of controlling the epidemic. And I think that's a very nice lead off into David's discussion of how things have played out here in the US, and in particular with respect to the vaccine rollout. So David, the floor is yours.
Thank you, Monica. I will turn the focus to the domestic situation in the United States and on vaccines in particular. The rollout of vaccines in the US is an important issue in its own right, but what I find even more fascinating and in some ways troubling is the extent to which the vaccine rollout serves as a mirror in which we can see both some of the amazing strengths and the gut-wrenching weaknesses of American society vintage 2021. In the next few minutes, I will illustrate what I mean by that statement. 4 key challenges hobbled the rollout of the vaccine in the early going. First of all, there was a limited supply of doses from the manufacturers that was available to be injected into people's arms. Secondly, there was insufficient capacity for delivering doses into the arms of people. Orchestrating that effort turns out to be very difficult, especially in pandemic circumstances when resources are needed in part for treating patients, and it was difficult to divert them into the job of delivering vaccinations. Thirdly, the rollout initially was grotesquely inequitable by race and ethnicity, especially as well as by socioeconomic status. And then finally, what was all too evident was the widespread hesitancy among significant components of the population to accept the vaccine when offered. What we've seen since then is that there has been substantial recent progress on the first 2 challenges, but the third and fourth still require our urgent attention. This slide shows the progress in the delivery of vaccine doses from the CDC to states and other similar jurisdictions. That is shown by the brown line. And what you can see is that through mid-February, deliveries of doses were hovering in the neighborhood of about 1 to 1.5 million doses per day delivered. During that period of time, the public health infrastructure was struggling to ramp up and get the bandwidth to deliver doses into the arms of recipients. That's shown by the blue line. For the most part, it kept pace with the stock of available vaccine that was being sent to them. You can see from the shaded area that the bad weather that struck the central part of the country in mid-February dealt quite a serious blow to the effort, albeit one that was temporary. Since then, there's really been quite a bit of progress made. The volume of doses administered has moved up recently into the range of 3 million doses, and the supply has stepped up even faster, up to 4 million. What you can see from the gap in the difference between supply shown by the brown line and take up by the blue line is that there is implied an increasing stock of backlogged doses. And you can see that in this chart. What we now have is a backlog of more than 50 million doses at the moment that have been delivered by the CDC to various state and other authorities. At today's pace of about 3 million doses per day, that's about an 18-day supply. So as much as the pace of injection has increased, it still hasn't kept pace, and so that will be a significant ongoing challenge. Hesitancy, even from the beginning, was identified as a significant challenge. Thankfully, across the country as a whole, hesitancy seems to have receded somewhat. These bars are taken from the survey conducted by the Kaiser Family Foundation and represent the aggregate of individuals who respond that they will either wait and see about taking the vaccine, they will take it only if required, or they will definitely not take it. And what you can see is that there's been a steady downtrend. Some of that seems to reflect the experience of individuals seeing others around them receive the vaccine and not have any significant adverse experience, and indeed be protected from contracting the disease. There do remain important pockets of skepticism about the vaccination. These results come from a survey conducted by NPR and PBS NewsHour and Marist. Still, in early March, it was the case that among all adults, 30% of adults reported that they would not take a vaccine if it was available to them. The pockets where this is especially concentrated, as you can see, among Republican men, nearly half among those who supported Trump in 2020, 47%, white men without college degrees, 40%, and white evangelical Christians, 38%. One dimension of skepticism that seems to have receded, and quite encouragingly, is that in earlier surveys, there appeared to be significant discrepancies by race and ethnicity, and those collapsed, both in the Kaiser Family Foundation survey and in the NPR et al. Survey. That's the source of the results shown here. That said, it remains the case that doses are still being distributed grotesquely inequitably. What this graph does, let me step back and explain this graph bit by bit. The blue bars show the ratio of hospitalization rates for 3 different groups relative to the hospitalization rate for white Americans. For American Indians or Alaskan Natives, you can see that 3.7 times the rate is being hospitalized for them as compared for whites. For African Americans, it's a ratio of 2.9 times, and for Hispanic or Latino persons, it's 3.1 times. Deaths are also being disproportionately suffered by these groups, as you can see by the brown bars. And by contrast, these groups are being under-vaccinated. Data are not available for American Indians and Alaskan Natives because there's a separate collection effort through the Indian Health Service. But what we can see is that for Black or African American persons and for Hispanic or Latino persons, they are being under-vaccinated, which is unjust in its own right, and all the more horrifying given the disproportionate experience of the disease in those populations. So what lessons do we take away from these experiences for the pandemic age? First of all, it will be important to maintain manufacturing capacity for the vaccine. This is a challenge that may to some degree take care of itself if and as the disease remains a chronic feature of the landscape. Secondly, it's very clear that we need to invest in public health infrastructure, which has been starved over the past decade or two of funding and the maintenance. This is the kind of thing that is needed in emergency times and often allowed to go fallow in the in-between times when we don't have the felt need quite as severely. Thirdly, it's incumbent upon us to focus on dismantling structural barriers by race and ethnicity. This is part of what is manifesting as the highly disparate experience of the disease for the groups that I showed on the previous slide. And fourth, we face the monumental challenge of attempting to restore public trust in things like science, in evidence, and in institutions that play such an important role in influencing our well-being. With that, I will turn it over to Mary.
Thank you, David. I think you've touched upon a lot of issues which are critical for the US, but not just the US. There are many nations around the world that are at the moment grappling with these harsh inequality realities that have emerged from the pandemic, or that were really already there, but have become even more visible and dramatic with the pandemic. Several groups within societies that have been marginalized and are having a very difficult time getting access to vaccines. And certainly investment in public health infrastructure is a key issue. Let me turn to Mary for a slightly different take, although very complementary to yours, on inequality and the aspects of inequality that are critical here for understanding the implications of the pandemic. Mary, please.
Thank you, Monica. I'm going to share my slides with everyone. And I will go to full screen, I hope. There we go. So it's, I think, a compliment to David's piece that we focus here on a particular form of investment in public health infrastructure, one that may not have been so obvious prior to this COVID-19 pandemic, but now clearly stands out, as has been noted by many observers across the country. And that is universal access to broadband internet. I also view it as an important way that we can begin to dismantle one of the structural barriers to equal access to public health services in the United States. This work is joint with my colleague at Peterson, David Hsu. So COVID-19, as we've seen in David's presentation, reproduced social disparities that were already present. Infection rates, treatment availability, and vaccine access all vary by income, race, and ethnicity. And one factor driving these differences in public health delivery is persistently unequal access to residential broadband service. This is not a new issue. It's something that we raised in our Rebuilding the Global Economy series in talking about having inclusive economic growth. But here we see that it's also vitally important for equal access to public health services. So in addition to skewing access to remote work and distance learning during the pandemic, a failure by the United States to provide universal broadband access has raised the mortality risk and reinforced existing social cleavages as a result of the pandemic. Internet access as a public health tool has not been obvious in the past. But it became obvious during the latest fight. So for citizens, home broadband access allowed us to easily access information about local spread of the disease and the kinds of precautions that we needed to take. It allowed us to access announcements of new vaccine clinics, and it allowed a way to complete state and local eligibility screening forms and sign-up lists. I'm sure that many people with us today have used the internet for all of these various tasks. From the public health perspective, however, high internet penetration really helps to reduce the cost of delivering this information to households. One of the things Martin mentioned in his review of East Asia and how they were able to successfully fight the pandemic was digital tracing. Something that has not been possible. It reduces the difficulty of contact tracing if we have universal access, and it reduces the complexity of ensuring wide and equal access to vaccine clinics. So lack of access is a public health problem, and in this work we focus on the role of the county. In the U.S. counties are a key player in the U.S. public health delivery system, yet counties contain very different populations, which means that they face very different challenges in providing information and access to the people who live within their jurisdictions. Some counties have populations which have very high COVID-19 mortality risks. And what we wanted to ask was, were these risks distributed across space similarly to a lack of broadband access? Broadband access varies across counties due to three factors. First is whether there is infrastructure in place. It's well known, for example, that many rural areas lack access to broadband access simply because the pipes are not in place. Secondly, counties vary widely in their median family incomes. And we know that household income is strongly associated with residential internet uptake, mainly because it costs money every month to have an internet connection. And third is digital skills. Those of us who have had to connect new devices at home and yell for our teenage children for some assistance know that it's not that easy to keep up with changing technology, and it can be quite intimidating for people who have not had access to those skills through their workplace or educational place, or just have more difficulty in accessing by language or technical skills. Lastly, the important point here is that this is a spatial problem. Due to spatial clustering of households by income, by race, within and across counties, we're going to have some counties that have higher public health needs and which are going to have differential connectivity to the internet. So do less connected places have higher needs? That's the question we looked at. So we highlighted the spatial clustering of both residential broadband service. It is, after all, infrastructure, and therefore has a spatial dimension, and pandemic risk factors, which also cluster due to the clustering of households. We find that US counties with the highest share of vulnerable residents are also places where fixed residential internet service is least common. This link between poor health and digital isolation understands the challenges that are faced by US counties, struggling to provide equal public services to all their residents. So in a sense, these two factors combine to mean that some counties are having to fight this with one hand tied behind the back. How did we investigate this connection? David and I drew upon publicly available data from the FCC called Mapping Broadband Health in America and the US Senate. And what we decided to do was to sort counties into quartiles, basically 4 bins based on health or demographic characteristics of the populations in those counties. For each quartile, we then calculated the average share of county households with fixed residential broadband service as reported by service providers to the FCC. Here we have to note that the residential service that we observe through the FCC data may be of very low quality. It may just be an old dial-up modem, for example. So what we are presenting can be considered a best case scenario about internet access among certain counties. Here's a picture that I think describes what we find for the wide variety of health characteristics. Here we look at counties sorted by the share of their populations that either are listed as obese or have diabetes. The first quartile, that is counties with the lowest share of residents who are considered obese. Among those counties, only 19% of households have no internet access. For the second quartile, it's 27% have no internet access. Third quartile, 31% have no internet access. And in the fourth quartile, that is those counties that have the highest share of obese residents, 37% have no internet access. Now, one thing we learned about the pandemic is that obesity is a strong correlate of mortality risk from COVID-19. When we look at another noted comorbidity, diabetes, we see the same pattern. Among those counties that have the fewest residents, residential share with diabetes, only 21% lack internet access. Among those counties with the highest share of residents that have diabetes, almost 40% have no internet access. This relationship holds for other types of health characteristics as well as income. We were interested in digital access and counties that had a lot of elderly residents or those that had a lot of non-white non-white residents. And here, non-white we define as Black, African American, or Hispanic populations. Among each of these individually, the results are mixed. Some elderly counties have a very high uptake of residential broadband. Among others, it's very low. Because residential broadband is highly correlated with household income, and because elderly residents vary widely along this characteristic, there was no clear relationship between the share of elderly in a county and residential broadband access. There was a small positive correlation. We found the same thing for non-white populations. However, when we divided counties into younger counties, those who had below median shares of elderly residents, and older counties, we found an important relationship. And the relationship is in that either grouping, those counties which had the highest share of Black, African American, Hispanic households, internet access was counties that have an above median share of residents who are elderly. We find that it is those older counties who also have a high minority share who have the lowest share of households with internet access, only 39%. So it's the oldest it's counties with the oldest, less and fewer non-white residents who really have the biggest gap. And this may help to explain some of the inequalities and disparities that David highlighted in his talk. Okay, let me just finish here with the fact that the failure to invest in the past has left us vulnerable. Counties with the largest share of residents with noticed comorbidities have the lowest residential internet uptake. Counties where equal access to state resources is of concern, particularly larger shares of rural residents, larger share of minority residents, have the lowest residential internet uptake. And the differential access across counties has will hinder detecting the next pandemic and protecting all citizens equally. Clearly, we need to do more for a fair fight. We highlight three things. One is investment in infrastructure needed to make high-speed internet access universal. Second is assisting low-income households' ability to afford basic service. And lastly, continuing to fund efforts by community anchors, such as libraries and schools, to assist those who actually need help, the digital skills needed to get online. Okay, I'll leave it there. Thanks very much.
Thank you, Mary. That was a very, very interesting set of findings. In particular, the set of findings with respect to these comorbidities, which seem to affect, we know do affect certain communities, which tend to be lower income communities. And at the same time, these are also the communities that are lacking internet access, and therefore they get sort of the double negative shock on their health from, on the one hand, being in those communities and being more affected by COVID, in the case of COVID specifically, but then on the other hand, also not having the sort of broadband access that's needed to access health services. So that is a very, very interesting way, I think, of tackling or addressing the inequality angle. Maury, the floor is yours as co-editor, and your any remarks you want to make.
Thank you, Monica. What I'd like to do in these closing remarks is just return to some of the themes that motivated Peterson Institute to bring out this briefing. It's 1 year, basically, since the pandemic really hit the world hard. And a year ago, we issued a briefing how the G20 can hasten recovery from COVID-19, and we warned against nationalistic responses to the crisis. Now, many lives were lost because some national leaders prioritized politics over public health. And I think Martin's presentation showed what a difference good governance can make. But opportunities to do better than we did were also missed because countries tended to turn inward. For example, they restricted medical exports, and there was a lot of finger pointing as opposed to collaborative communication. Fortunately for all of us, science and industry subsidized by governments developed effective vaccines in record time, some based on new technologies from which we will benefit in the future. So once again, we face opportunity, but we also face risk. Immunization is proceeding fast in the US, and it will accelerate in the EU. But the distribution of vaccines is lopsided within countries, as David has pointed out for the US, and also internationally. Poorer countries lag badly. As of mid-March, the Kaiser Foundation reported that rich countries had purchased enough vaccine doses to inoculate their populations twice over, while poor countries had purchased only enough to cover 1/3 of theirs. This is a big problem for the entire world. Developing countries, as well as unvaccinated pockets in richer countries, will remain potential incubators for variants of concern of the SARS-CoV-2 virus. And these variants, if they develop in one country, will spread inevitably to other countries. Brazil's P1 variant is a deadly cautionary tale. As of 2 days ago, Brazil experienced almost 4,200 deaths due to the virus. And the virus is spreading, it's rampant. This variant is rampant throughout South America, and it's also appearing in the US. This is a news item from yesterday afternoon. The state of Michigan, which previously had detected 4 cases of P1, detected 2 more. Brazil is also having, Michigan is also having an unusually big surge in cases. So this may be just the tip of the iceberg, given how weak US genomic surveillance has been. A key challenge is to avoid vaccine nationalism. Countries continue to squabble over vaccines, and a number of the big producers have explicit or implicit export barriers. But vaccine equity is to everyone's advantage within as well as between countries. As we say in the briefing, no one is safe until everyone is safe. Richer countries have to make every effort to deploy their surpluses quickly. It's great that the Biden administration has pledged $4 billion to COVAX, but the money won't help unless COVAX has doses to give out. We need enduring reforms, not just responses to the current crisis. This pandemic may persist given the proliferation of VOCs and given the slow and uneven pace of global vaccination. There are going to be long-haul physical and mental effects, so public health systems need to be strengthened at the national level and also for future challenges. We face zoonotic and man-made pandemic threats. These come from encroachment on habitats, from resistant microbes, even from the possibility of terrorist bioattacks. And we should have invested much earlier. In fact, this disaster was predictable, and future disasters are perfectly predictable. Let me give you a quote from Ron Klain, who is now better known as Joe Biden's chief of staff, and this is from STAT, February 2016. And it's so prescient that I want to read it. He said, "The world faces a pandemic threat that's very different from Ebola, some kind of pandemic flu that is airborne and transmitted very easily and very rapidly. It could break out in a global megacity, in a densely populated area. It could break out in a country where lots of travelers every day come to the United States. It could break out in a country where 3,000 US troops would not be welcome, where thousands of US volunteers would not be welcome. And I still think as a country and as a world, we're not prepared for that." And if that sounds familiar, then we should be asking, how do we prepare for next time? National reforms are key, and the presentations by David and Mary highlighted that. But we also need a global agreement a global pact that would bind countries to a cooperative approach. Our briefing includes a chapter by Chad Bowen and Thomas Boyke that proposes a coronavirus vaccine investment and trade agreement that would safeguard global supply chains and enable the world to scale up global manufacturing and distribution very quickly. But global cooperation is needed in other areas, including, very importantly, genomic surveillance of ongoing and potential threats, supply stockpiles, strengthening the WHO. In February, the G7 endorsed, quote, exploring the potential value of a global health treaty. And on March 30th, more than 24 world leaders from industrial and developing countries, including Boris Johnson and Angela Merkel, endorsed a global pandemic treaty that could encompass the many areas of common concern needing cooperation. Unfortunately, the US, India, China, and Russia were not parties to this March 30th statement. What's the chance for this? Well, judging from what's happened so far, it doesn't look great. 80% of the exports of goods that are needed to fight pandemics come from only 20 countries. And these countries are mostly members of the G20 and the OECD. And so it's natural that the G20 should take the lead. The G20 finance ministers and central bank governors met yesterday in Washington, well, remotely in Washington, and issued a communique that failed to take up this idea strongly. They expressed all the right goals, but disappointingly, they expressed no concrete means to attain them. There is a G20 high-level independent panel on financing the global commons and pandemic preparedness response. I hate to think of what the acronym for this is, but it's supposed to deliver some proposals in July. There's a G20 health working group that's doing fantastic work studying resilience and international coordination on health, drawing on the One Health approach that integrates environment and health, and that many countries have endorsed, but have done much less concrete to follow up. But how this will play out and whether the G20 leaders will endorse this is a question. The G20 leaders don't meet until October, and time is really running out. Even though we have vaccines, this virus is nowhere near over throughout the world, and there will be future threats. Political leaders have to step up. We are still definitely in a crisis, and future crisis could be closer than we think. Thank you.
Thank you, Maury. I think that was a wonderful summary of the many issues we have tried to grasp in this PIIE briefing that we put together, and the many policy, not just recommendations, but challenges that remain before us. The global cooperation angle being the key challenge that we still have basically failed to address, even though we're now more than a year into this pandemic. And with these variants of concern now spreading widely across the world, and other variants of concern popping up in different places. So there's still a lot of work to be done, and we do hope that the international community at some point will take up this issue seriously, because we cannot have, as we've been emphasizing throughout our policy briefing, we will not have this pandemic under control unless it is really under control everywhere. We have a few minutes left for questions, and there are some questions here in the Q&A. There's one specific question for Mary, and Mary, I'll direct that to you. So this is a question from Sarah Box, and she's saying, thank you, Mary, for a very interesting presentation. Your observation that internet connections are critical for inclusion and fighting inequality aligns with the OECD's new recommendation on broadband connectivity, which urges action to boost high quality connectivity. In your research, do you think using mobile broadband statistics would have changed your results at all?
Thanks for that, making the connection to the OECD report. By mobile broadband, I'm assuming you mean smartphones. And yes, it would have. Smartphones are somewhat more widely available. We have programs for the low income that provide some basic limited smartphone service, so data limited. Unfortunately, smartphones are widely considered not adequate for the task of contact tracing and for getting public health information. It's very difficult, particularly for older people, to type on a smartphone, to download forms, to then print out those forms and bring them to vaccination lines. So we do have just a little bit in the paper about this, but we focused on residential internet access. Another reason to focus on residential internet access is, of course, that there's been a push for greater inclusivity in the economy and a return, focusing on tradable services, for example. And so residential internet access will be needed for that type of inclusive economic development as well. So thanks for the question. I think it's really great. Mobile access is more widespread, but we think it's not up to the challenge.
Thank you, Mary. There's still a couple of, I think, very provocative questions, one which I'll pose to any of you who wants to address it. But I think, Martin, you perhaps might want to touch on this, and maybe Maury and David. So the question is by Vandana, so I can't pronounce the last name, and it's COVID-19 variants imply new and fast waves of the pandemic and an impending challenge to the effectiveness of vaccines to tackle different variants of the virus. In designing the pandemic response measures, should states prioritize curbing infection rates, thereby ensuing lockdowns, which has a serious impact on the economy and livelihoods, or promote a compulsory and efficient vaccination campaign, which may have a serious impact on the liberty of individuals to choose whether to get the vaccine or whether to get a particular vaccine at a given time?
I can take that up a little bit. I mean, one of the things I think we've learned from the pandemic is that the lockdowns are really a mixed bag, because you can't lock down everything. Some people still have to go to work. Medical workers, for example, someone has to deliver food to people who are in their homes. So there's no way to fully bring infection rates down to zero. And it's not clear that that actually ends up working. And in addition, without these kind of travel restrictions, you can, unless everywhere in the world locks down at one time, you're still going to have new variants coming out and new infections happening outside the country. And it's going to be really hard to keep them out. On vaccines, I think it's important. I don't know much about how this works in other countries, but I know in the United States, if you want to send your kids to public school, you have to prove that they're vaccinated, because this isn't just a civil liberties individual choice issue. If your child is not vaccinated for measles, let's say, it could spark an outbreak in the school and negatively affect other people. So this is not just an area where the individual makes their choice and it doesn't negatively affect other people. If you choose not to get a vaccine and you infect other people, or you become a breeding ground for a variant, you are massively negatively affecting other people. And I don't think that should necessarily be fully left up to choice. Now, if you want to not get a vaccine and then not be around in public spaces that decide to demand vaccines, that's one thing. Government probably shouldn't tell everybody they have to get it, but businesses and schools and other areas should be free to tell unvaccinated people that, people who choose not to be vaccinated, that maybe they can't be there because they're putting other people at risk.
Thanks, Martin. There's a comment here by Andrea Brandolini. You're right on the importance of the G20. There was no statement in the G20 communique yesterday, but preparedness and prevention against future epidemic challenges is very high in the Italian presidential agenda. The high-level independent panel will provide concrete proposals for financing such tasks. Let us see during the summer whether we can move forward by taking serious commitments. Indeed, that is very urgent and necessary. So I think all of us hope that will happen. There were many questions here related to, I think, Chad's piece, which Maury discussed a little bit, but which of course Chad discussed at length on Tuesday. And they all have to do with the investment aspect of the trade agreement that is proposed in Chapter 10 of the PIIE briefing. So that's the joint chapter by Chad Bown and Tom Boyke. And I would refer people to that particular chapter because they do detail quite extensively, actually, how that agreement would work and how you might be able to get investment going and cooperation on investment and trade going for vaccine manufacturing and vaccine distribution. I do want to call the attention of everybody to that particular chapter because it does have a really interesting chart, which essentially lays out what a vaccine supply chain looks like. And I think many people don't realize the complexity of vaccine supply chains. And these two colleagues have made a very a fabulous effort, actually, at trying to get at the complexities of vaccine supply chains and how you can't really think of separating out portions of the supply chain because all of it has to work together, which of course speaks to the issue, an issue that has come up in some questions of patents, and whether or not we should think about removing patents or breaking patents. And of course, breaking patents does not resolve the issue of supply chains because, to the extent that you do need cooperation on supply chains because certain countries produce certain types of raw materials, other countries produce equipment for vaccines, and all of this has to come together in order for vaccines to be produced. The patent issue doesn't really resolve that very basic problem of coordinating to produce and distribute vaccines. So in all, unless any one of you wants to add an additional comment, okay, so I will then refer everybody who's been with us this morning to the PIIE briefing. It's on our website. It can be downloaded and read for free. And all of the chapters are in there, and with a lot more detail into many of the presentations that we have made over the course of these 2 days, Tuesday and now today. And I would now like to thank my distinguished colleagues and adjourn this meeting. Thank you very much.